welcome back everybody. Just like a live conference, a slightly late start after lunch, but it's not due to a second bottle on this occasion, it's due to some technical hitches, which we think we've ironed out. So our third session of the day is an upper GI surgery focused EGS session. And I'm going to hand over to Professor Sagar to introduce our first speaker.
Thanks, Jill. The first speaker is Sarah Richards from Bath, who's going to address the topic of ambulatory management of right iliac fossa pain. Sarah.
Chair people, ladies and gentlemen, thank you for the opportunity to discuss the topic of ambulatory management of right iliac fossa pain and to go through some of the detail of what we've been undertaking in Bath. Next slide, please. So I think we should be straight compared to many of the talks that we're going to hear about today. To many surgeons, this is not the most exciting problem we encounter, but however, it is a problem of significant scale. So within the UK, each year we have approximately 70,000 confirmed diagnoses of appendicitis, but the referrals with right iliac fossa pain query appendicitis are significantly higher than this, in the order of 3 to 4-fold higher than this. And we know that many of these patients spend a long time in hospital, even if they don't have surgery. And some data out of Ireland suggests that their length of stay was as long as 4.8 days. Certainly in our hospital, prior to implementing a pathway, it was about 2.5 days. And so this is a significant healthcare issue, and there has to be a better way to manage these patients. And next slide, please. So for a little while now, certainly the physicians have been talking about red and green hours and days where patients spend time in hospital. And a red hour is where absolutely no intervention or any movement is made forward with regards to those patients. And green hours is where actually an intervention or procedure is undertaken which would move a patient's stay onwards. We looked at our right iliac fossa pain patients that were admitted to hospital. They were spending, as I say, about 2.5 days in hospital, not having an operation, but only 8% of the hours spent in hospital was there any intervention or any management being undertaken which moves their time and speed of their diagnosis forward. And we felt we should really value our resource better and protect our beds, but more importantly, we should value patient time, and if they don't need to be in hospital and there's a better way of managing them, we should do so. Next slide, please. Is it safe though? There has been quite a lot of evidence published recently that suggests that actually a 24-hour wait for surgery in a patient, even with known acute appendicitis, does not increase their complication rate. And if we know that we have a bit of time in the system in order to get the diagnosis correct, surely we could streamline diagnoses, investigation for this group of patients so that they don't have a lengthy time in hospital waiting for a diagnosis to be made. Next slide, please. So with this in mind, we developed a right iliac fossa pain pathway. This is underpinned by an early clinical conversation. So a patient is referred and they talk to a clinician at that point. We have looked at various protocols, but actually we feel strongly that nothing can replace a clinical conversation. At that point, it is decided whether the patient is unwell enough that they need to be seen and admitted that day, or whether they can wait for our next ambulatory care appointment. That would happen the same day or the next day. Once they're seen in emergency surgical ambulatory care, which is a dedicated area with a senior decision maker with dedicated diagnostics and staff, a decision again is made whether they're unwell enough that they need to be referred to the take or whether they can continue to be managed on an ambulant basis. If they can continue to be managed on an ambulant basis, we have our own dedicated theatre lists where we would undertake day case laparoscopic appendicectomy. Or if the diagnosis is unclear, we have rapid access to CT or MRI scan. Or we can see them the next day again in emergency surgical ambulatory care and continue their observations on an ambulant basis. And the whole pathway is underpinned by robust safety netting, documentation. The patient is given details as a telephone number they can phone should they become unwell at any point on this pathway while they're at home. Next slide, please. So we developed our pathway in January 2015, and the number of patients that we have seen has increased year on year. But in total, we've now seen 661 patients on this pathway. And not unsurprisingly, there's been a great preponderance for women over men. Actually, if you look at the data, very few were of confirmed appendicitis that we managed to manage on a completely ambulatory basis. But the times for these patients, they're seen within a consultant review within 14 minutes of arrival in the building on average, and they get a written ultrasound report within 42 minutes. If they then need theatre, they are done that afternoon on our dedicated emergency list. And if you look at the patients managed over the same period of time on the traditional take and then have their surgery on the NC-POD list, their wait for theatre is considerably longer. Under investigations done, well, they're, as you would expect, right iliac fossa pain patients to experience. And certainly it's a diagnostic heavy pathway where we occasionally also need rapid access to CT or MR. Next slide, please. So our outcomes are good. And actually it's the non-specific abdominal pain group of patients where we seem to manage them most effectively and confer most bed savings. The savings are not insignificant, and this particular group of patients seems to do proportionally better. They get 20 minutes of a consultant's dedicated time, rapid access to diagnostics, and are sent home. And if we look at the 30-day follow-up on this patient, of which there have been 369, only one has represented within that 30 days, went on to have a laparoscopy, which incidentally was normal. And as we become more confident in our pathway, month on month, the numbers being referred to us are increasing. Next slide, please. So for those that want to introduce an ambulatory care pathway for right iliac fossa pain, what would we recommend if you wanted to ensure it was a successful service? Well, firstly, the area ambulatory care must be protected. It can't be an area that's bedded overnight and then collapses. You must have engaged and motivated junior doctors that are willing to take that referral and have the confidence to put it through on an ambulatory care pathway basis. You need support staff, particularly administrative support, nurse practitioners to support the pathway, and rapid access to diagnostics. We have our own dedicated theatre list to manage this group of patients, and it must be safe with information sheets, a telephone number for the patient, and robust safety netting for those patients that might become acutely unwell. Referrers need to be aware of the pathway, and increasingly more patients are being referred by a general practitioner asking for them to be seen in emergency surgical ambulatory care, particularly as when we share the data, we can show that these patients are seen and operated upon quicker than if they come through the traditional pathway. It is, however, expensive to front load senior diagnostics, senior clinician makers and diagnostics. So think about how you're going to charge your stakeholders an appropriate tariff. Collect all your data. But the caveat to all this is keeping patients out of hospital is hard work. And please don't be tempted to simply park them in a bed and manage them in the traditional way as we go into winter. Next slide, please. So as always, this is a team. Without a big team behind us, we wouldn't be able to manage our patients in this way. And I'd like to thank the whole team here at Bath. Thank you very much.
Sarah, and congratulations on the work you've done down in Bath. I'm sure there'll be some questions on that later. Jill, hand over to you.
So I'd like to introduce our next speaker. Again, really pleased to introduce a friend and a colleague from Derby, who's the Director of Education for the ALS GBI, Paul Leader. Thank you, Paul.
Thank you, Jill. As you say, I'm speaking on behalf of ALS GBI, but I'm also the emergency colleague with Jill, so she'll be very familiar with what I'm about to say. Next slide, please. For brevity, I'll just be focusing on the areas on the left side of this talk, mainly diagnostic laparoscopy, perf, DU management, small bowel obstruction, incarcerated hernia. I think laparoscopy is well established for appendicitis and cholecystitis, so we're not going to be discussing those. And as an upper GI surgeon, I think diverticulitis is out of my remit, and it was also previously discussed earlier today. Next slide, please. There's good international consensus on the use of laparoscopy in the acute abdomen, and I think it's important to look at these. There's an excellent publication on the role of laparoscopy in emergency abdominal surgery published in 2011. So anyone that's particularly interested, then please do look at this publication. Next slide, please. If we go on to diagnostic laparoscopy, what I would invite people to take away today is that I think this should be used as default in majority of acute abdominal situations, particularly in stable patients. It's useful to confirm imaging findings, particularly when CT hasn't made a definite diagnosis. You can carefully assess the whole of the abdominal cavity, and limited therapeutic interventions include aspiration or irrigation and placement of drains. Even when a laparotomy is needed, then this can be targeted as a mini laparotomy. And I think at the bottom of this slide, you'll see the obvious advantages that have been highlighted of laparoscopy over laparotomy, with long-term reduction in adhesions and particularly incisional hernias. Next slide, please. With all these significant advantages, why is laparoscopy still not commonplace in the UK? I think there's several reasons for that. We've all experienced the reluctant theatre team, particularly out of hours, who groan whenever a laparoscopic approach is mentioned. And that may be because the team you're working with are not specialised in laparoscopy and not au fait with the equipment being used. And another particular issue is of training. The operation may turn from a classic registrar laparotomy to suddenly being a specialist consultant-only laparoscopic case, but this doesn't always have to be. Surgeons are also reticent because of the difficult access, particularly on a grossly distended abdomen or where there are multiple previous scars. Next slide, please. I think it's important to look at several areas and to make laparoscopy safe. The first thing is choosing the right patient. Hemodynamically unstable patients is probably not suitable for laparoscopy, but in stability, it's a useful technique to use. It's important to educate the theatre staff and make sure you're au fait with the equipment, particularly out of hours. This video is just showing a classic optical port in Palmer's Point, and this is a standard safe approach, and it's important to familiarise yourself with both this technique and also open cut downs away from previous laparotomy scars. The other issue is to look at careful bowel handling. Please be aware that atraumatic graspers are not particularly atraumatic, and I think it just comes with experience knowing how to handle bowel carefully. And look at educating yourselves in the advanced laparoscopic techniques, particularly laparoscopic suturing. Next slide, please. Next slide. Perforated peptic ulcer is an area that is useful. Often CT scans may identify perforation with not an obvious site identified. So even as a diagnostic tool, I think it is useful and as a good alternative therapeutic option compared to the open approach, particularly in the stable patient and where the diagnosis has not been delayed. Next slide, please. The video. This video is from my colleague Avril Chang. I work with her at the Royal College of Surgeons, and we show this video as part of our core laparoscopic skills course. And the reason for showing this is really just to show that these laparoscopic skills should be attainable for all general surgeons in acute phase and part of their standard training. Learning one of these slip knots is ideal in management of a perforated duodenal ulcer to close the hole securely and also to securely place an omental patch, as well as learning a proficient knot tying technique. Adequate lavage is perfectly adequate with laparoscopy compared to an open surgery. Next slide, please. There's a good Cochrane review looking at the advantages of laparoscopy over open surgery. These will be well known to you: reduce abdominal wall complications, reduce respiratory complications, and early return to full mobility. There was some potential disadvantages highlighted of increased leak rate in abdominal collections, but I think these are mainly due to the experience of the surgeon, and with increasing use of laparoscopy, these should be reduced. Next slide, please. I think the most important area of the increasing use of laparoscopy should be in the management of adhesive small bowel obstruction. Majority of small bowel obstructions are adhesion related, and these can occur some years after laparotomy. So it's important to avoid laparotomy if possible. And it's always worth having a look. People are worried about massive bowel obstruction, particularly in perforation or hemodynamic instability. Laparoscopy may not be suitable, but most other cases it is a reasonable option. Next slide. One of the main advantages of laparoscopy is that it aids diagnosis, and this is an all too familiar situation where when we have a look inside, we just find a single band adhesion, and it would be a tragedy to put this patient through a full laparotomy when the whole operation can be completed within 5 or 10 minutes. And if you have the appropriate laparoscopic skills, then any potentially non-viable areas can be reinforced with simple suture techniques. Next slide, please. Again, there's a Cochrane review that suggests a variable success rate, but even at 50%, I think this is still worth doing. The reasons for failure were multiple previous operations, a delay in diagnosis, and the finding of extensive adhesions. But if you avoid laparoscopy in 50% of patients, then it is still worth looking at laparoscopy. Next slide. Last area to cover is incarcerated or strangulated hernias. Now, laparoscopy is used as a standard place for hiatal hernias, and I won't discuss those today, but I'm more interested in the use of laparoscopy in abdominal hernias in the acute situation. And this is a suitable approach in selected patients. There's limited published evidence to validate it over open repair, but I think it is a useful alternative, particularly where you have the appropriate skill set. Next slide, please. This video is from one of my colleagues, Altaf Awan, that I work with. It's a beautiful presentation of management of a strangulated Richter's hernia. I think there are 2 points here. One is to note that placement of mesh is a safe thing to do, even when there's potential small bowel contamination. And also that with the appropriate skill set, using stapling and suturing, that bowel can be resected and reanastomosed safely using laparoscopic techniques. And I'd just like to plug our ALS-GBI courses. We have our first face-to-face course after COVID running in December. So if people want to go on the website, they can look at experiencing these techniques firsthand. Next slide, please. So in summary, I would commend diagnostic laparoscopy as being a default procedure in the acute abdomen. There is limited value in a hemodynamically unstable patient, but in the majority of stable patients, it should be used as a first-line approach. And really, the extent of your therapeutic options are just limited by the skills of the surgeon and the equipment available. Last slide. So I would commend all trainees to become empowered I think it's important to learn how to set up the stack, particularly when working out of hours, to deal with the reticent theatre staff. Learn those safe access techniques of open and optical port insertion, and also go on a course and learn laparoscopic suturing. Once you've become au fait with these techniques, then it's surprising how often they can be used safely. And just have a go. I think with the appropriate skill set, you really don't have anything to lose. Thank you.
Thank you very much, Paul. That was excellent, and you kept time, which is great. Over to you, Pete.
So on a similar theme, Stuart Mercer is going to give his spin on the topic of laparoscopy in emergency general surgery. Stuart's from Portsmouth. Stuart, please. He's out and about in Portsmouth.
Can you hear me?
Hi, can you hear me?
Yes, now.
Hello, can you hear me?
Yes,
Yes, fire away.
I was just thinking.
Do you want to give me the slide back while he fiddles?
Okay, perhaps while we're waiting for Stuart to get back on, we'll go with Tom Weiser. Tom, are you available?
Can you hear me there?
Yeah, we can't see you though.
Where is the screen slide? Right, that's us. Hello, sorry about
Right.
this technical hitch. We're going to let Stuart give his presentation one more go. And if not, we will have to not allow him to do
Right,
that.
here we go.
Go, Stuart.
Can you hear me now? Can you
Yes.
hear me talking? Right,
Yes.
I'll crack on and we'll see how we get on. Look, thanks very much for inviting me to speak about one of my favourite subjects. Paul Lead has been telling you about how to do laparoscopy in the emergency setting. Next. Portsmouth has a pretty hectic emergency surgery service. Back in 2014, we put together a group of clinicians to look at the findings of the NELA organisational report, and we used it as a spur to make improvements to our service. And amongst the changes we made, we recognised that most of our surgeons were pretty good at keyhole surgery, and we saw no reason why this skill shouldn't be applied to our emergency patients, as well as to our elective patients. Next, please. This chart shows our increasing implementation of laparoscopic surgery over the 6 years that NELA has been running. Can you skip that one, please? In the first year, it was attempted in 38% of cases and was successful in 25% of cases. And currently, we're running about 75% of our emergency cases are started laparoscopically, and around half of them we complete laparoscopically. Next, please. Over the same 6 years, our median post-operative length of stay has steadily reduced from around 11 days to about 8.5 days. Now, this is certainly multifactorial, but it is reassuring. Next. More surprisingly, our post-operative mortality has dropped at a similar rate, from 9.5% in 2014 to about 6% last year. Again, multifactorial, but it does mirror the more widespread use of laparoscopy. Next, please. It is worth asking the question why people don't offer laparoscopy in the emergency setting. And Paul Leader mentioned a few of these. Personally, I think it lies within the skill set of most modern day surgeons to do laparoscopic emergency surgery. I think the main barrier is that simply people don't think of it. They don't consider it as an option, and because they're not convinced of the benefits of it, or they're not aware of what can be achieved. So hopefully Paul's talk and then what I'm about to show you will convince you that the results do make it worth having a pop at it. Next, please. 18 months ago, we made a formal request. Can you skip that one? 18 months ago, we made a formal request to NELA for a data set so that we could analyse the effect of laparoscopy in emergency surgery across the entire country. For various reasons, it does take a while to obtain data from NELA, but eventually we were sent the details from the first 3 years of NELA of around 120,000 patients. Next, please. This chart shows the variation in uptake of emergency laparoscopy between hospitals across the country. Each line represents a hospital. Red means open surgery, and green means a successfully completed laparoscopic operation. A few hospitals have an attempted lap rate of around 50%, but in over 80% of hospitals, over 80% of cases go straight to laparotomy. Next, please. This is a very crude analysis, but it does show that the median post-operative length of stay for each hospital mapped against their rate of attempted laparoscopy. And it seems that patients might get home a bit sooner from hospitals where there's a greater use of laparoscopy in the emergency setting. Next. This box and whisker plot shows the average post-operative stay for all 120,000 patients, according to whether their surgery was completed by open surgery, attempted laparoscopically, and successfully completed laparoscopically. It demonstrates a shorter mean and median post-operative stay for patients where their emergency surgery is attempted or completed by a keyhole surgery. Next, please. This chart shows that the benefits actually carry over into crude 30-day survival. Patients whose surgery is attempted or completed laparoscopically have substantially lower 30-day mortality than those who go straight to laparotomy. I fully accept that there will be confounding factors with comorbidities, predicted mortality, previous surgery, but in Portsmouth, by the time we're trying 75% of patients by the laparoscopic approach, I think the effect of those confounding factors starts to be a bit less significant. Next, please. There are many ways of addressing these confounding factors without having to resort to the slow, tedious, pointless tool of a randomized controlled trial. You should all be aware that your hospital's NELA data can be analysed by comparing the actual mortality rate with the mortality rate that would be expected from your P-possum predicted mortality rate. Next, please. For every approach, we found that the ratio of observed to predicted mortality is better than 1, but the difference is most marked for patients whose surgery is attempted or completed laparoscopically. Next, please. We all know that the P-possum score is pretty accurate at the lower end of the range, but it overpredicts mortality at the higher end of the scale. In fact, that's why it's been replaced by the NELA risk score. Next, please. So we analysed separately the 90-odd thousand patients whose mortality risk was predicted to be less than 20%. This led to an even more pronounced difference in the ratio of observed to expected mortality. This graph suggests that for patients with a predicted mortality risk of 20% or less, they are around half as likely to die if their surgery is performed laparoscopically than if they go straight to open surgery. Next, please. Taking this a stage further, we looked at the 50,000 least sick patients who had exactly the same straight were half as likely analysis. Next slide, please. This last analysis removes the majority of the confounders or bias in the system. It confirms better survival across the whole of the keyhole approach. Indeed, it actually suggests that the surgical approach should be a major factor in future risk prediction models, since even attempting surgery by the laparoscopic approach seems to reduce mortality. Next slide, please.
That might be a good place to end it.
Thanks, Stuart. I think we've got the message. I think some of the sound problems there. I apologise for that. We've got your conclusion up there on the screen and a very clear presentation. Thanks, Stuart.
Right. I'm still here.
Still there. Do you want to conclude a couple of sentences?
Here we go. In conclusion, I hope that Paul Leader and I have shown you that laparoscopic surgery is safe and feasible in up to 80% of our emergency surgery patients, and that it's associated with a shorter post-operative stay and significantly lower mortality. Even if it has to be converted to surgery. However, as it stands, next slide please, as it stands, I suggest to you that the nationwide single thing that we can do to reduce the morbidity and mortality associated with emergency surgery. Thanks very much.
Thanks, Stuart. Thanks for getting through on dial-up internet. Jill, I'll hand back to you now.
Thank you. I'm just recovering from that. I think we need to institute decent Wi-Fi on the South Coast before we institute widespread laparoscopy. I feel for Stuart. He tried manfully, and I think his slides got the message across. So it gives me great pleasure now to introduce a foreigner in our midst, a visitor who emailed us last year to offer his services for this meeting, and I thought he'd been snatched from us by COVID, but you obviously got stranded on this side of the pond instead. So I'd like to introduce Tom Weiser, who is a visiting professor at the University of Edinburgh, who's going to talk to us about tough cases from across the pond. Thanks, Tom.
Yes, good afternoon. I'm going to take so I'm a general and trauma surgeon from the United States, currently based at the University of Edinburgh, and I'm going to take the opportunity to show a couple of cases that we've performed in the last few months, actually at Stanford recently. So next slide, please. So in typical fashion, I'll start really with kind of a case presentation. So this first case was a 59-year-old woman who had a history of an open cholecystectomy back in 2006 and subsequently underwent a laparoscopic Roux-en-Y gastric bypass 3 years later. And she presented to the emergency department with 3 days of nausea and vomiting, as well as some epigastric and right upper quadrant abdominal pain and some abdominal distension. She didn't have any fevers, no diarrhea, no bloody stools, no other shortness of breath. Next slide, please. And history and physical, her past medical history was mostly significant for her surgical history. She'd had a gastric band placed in 2005, which was removed during her laparoscopic Roux-en-Y gastric bypass. She'd had this open cholecystectomy in 2006 for cholelithiasis. She had hypertension that had resolved following her obesity surgery. She was not on any medications and didn't have any allergies. Next slide. And on exam, she was essentially fairly non-toxic. She was awake, alert, no distress. She wasn't jaundiced. Her vitals were relatively stable, other than a slight tachycardia and some slight desaturations on oxygen saturation. But her abdominal exam showed epigastric tenderness, a little bit more tender in the epigastrium and in the right upper quadrant, but she didn't have any peritoneal signs or focal peritonitis. Next slide, please. She did, however, on her blood work, show a substantial leukocytosis with an elevated white count, some thrombocytopenia, and most remarkably, a bilirubin of 7.0 with elevations of her transaminases. So she was on her way to what appeared to be acute cholangitis, and we proceeded to get some imaging studies. So next slide, please. And if you can use the video piece here. So this is her CT scan, and what you'll notice is some very remarkable intrahepatic biliary dilatation throughout her liver. She also had a hemangioma as well, and then pretty remarkable dilation of her common bile duct. Next slide, please. So you could see her biliary dilatation. Here's the intrapancreatic portion of her common bile duct. You can see a marked dilation of the common bile duct. Next slide, please. And then you can actually see at the distal end an impacted stone impacted at her ampulla. So this is a patient who has retained stone over 12 years following her open cholecystectomy with evidence of cholangitis. Next slide, please. So as a temporizing measure, we worked with our interventional radiologist because she was starting to get pretty sick to place a percutaneous transhepatic biliary drain. So that temporized our problem and provided biliary drainage and diversion. But she still had this retained stone stuck quite substantially at her ampulla. And because she's not eligible really for a typical ERCP because of her gastric bypass, we had to come up with an alternative way of accessing this. So we had two choices, either an open common duct exploration, but I decided to work with my interventional gastroenterology colleagues to do a laparoscopic assisted ERCP. So we basically cannulated the remnant gastric stomach in the operating theater. Basically what we did is we used a 12 millimeter trocar by her umbilicus to allow us to get a stapler through that 12 millimeter trocar when the time was right. 2 5mm trocars laterally, and then placed stay sutures up in the remnant stomach, brought that stomach up to the abdominal wall, and then you use a 15mm trocar to enter into the gastric lumen. And we use an OptiView trocar to do this, and this is really important. The 15mm is an important trocar to use because it allows introduction to the endoscope. Next slide, please. So here you can see the fluoroscopy. So this is you can see in the right upper area the clamps holding the sutures that are tenting the stomach up against the abdominal wall, the scope going through the trocar, and then this is how, using fluoroscopy, this is how the endoscopist is able to cannulate the duct. The next slide, please. So here's some endoscopic views. You can see the PTBD extruding through the ampulla, and you can also see the thin, clear cannula of the ERCP endoscope that's going cannulating the ampulla. Next slide, please. You can see the sphincterotomy with the sphincterotome now being deployed. Next slide, please. You can see dilatation or dilation of the ampulla following sphincterotomy. Next slide. And then a massive stone that we got out through this sphincterotomy. Next slide, please. So at this point, we'd solved her problem, and we had done it all laparoscopically, which was really nice. We restored pneumoperitoneum peritoneum, and obviously the bowel was pretty inflated with all of our insufflation from the ERCP. So we had left our trocar in place, able to identify that remnant stomach, and then through the 12mm umbilical trocar, basically stapled off the gastrotomy, and then extracted that gastrotomy sliver remnant through the 15mm port. And that was her done and dusted. Next slide. So the next case was a very, very tricky case. This was an 88-year-old man. So I know in the UK this patient might not have gone on to surgery, but an 88-year-old man with a history of situs inversus totalis. He had a history of right nephrectomy as well, and he presented at an outside hospital with multiple episodes of biliary colic. Next slide, please. So this is, if you show this video, so he's situs inversus, so the heart's on the right side of the chest. You can see as we go through, the liver is up in the left upper quadrant. All of his organs were totally reversed. He'd had a left or a right nephrectomy. I guess is a right nephrectomy, a left nephrectomy, and situs inversus. I don't know. Next slide. And so he underwent at the outside hospital an attempt at a laparoscopic cholecystectomy. Unfortunately, during this procedure, it looked like the surgeon at the outside hospital had transected the common duct. Obtained a intraop cholangiogram, noticed that, and then sent this patient on to us for reconstruction. Next slide, please. So you can see here is a picture of the intraop cholangiogram. You can see that the biliary tree is alight in the liver, but there's there's no contrast traveling through the common duct or into the lumen of the bowel. So next slide, please. And if you'll run that, so this is the CT scan that he had here. We wanted to make sure that there was no injury to the hepatic artery, which there wasn't. You could see that the surgeon had left a subhepatic drain. Next slide, please. And that there was no free fluid, nor was next slide. Nor was there any evidence of injury to the hepatic artery. So essentially, we did a left upper quadrant incision to reconstruct his biliary anatomy. Adhesions were lysed. We took the gallbladder down using a fundus down approach. Noted that the cystic duct in this case was extremely short, which was absolutely the reason for this intraoperative error. Because actually in situs inversus patients, there is some evidence of agenesis of the cystic duct. So you can have basically an infundibulum and then a very, very short neck that goes straight into the common duct. The common duct was found transected and clipped, and so we reinforced the distal end with a PDS suture, and then created a hepatocogyginostomy using 5-0 PDS interrupted sutures. So obviously this is all backwards. Next slide, please. So here's an intraoperative picture, and you can see the reversal. So he's got his falx to the patient right of the cystic of the common duct. You can see the common duct tented up in the middle of the screen there, and then our jejunal limb brought up for our reconstruction. Next slide. And if I have a few more minutes, I'll do our last case. This was a 42-year-old man. He was a Mexican national, with a history of latent TB. He had just recently been diagnosed with TB and was undergoing treatment with rifampin. And he had a one-day history of right lower quadrant pain without any fever, chills, nausea, or vomiting. Next slide, please. He had no prior surgical history, didn't have any other major risk factors, and no allergies. Next slide, please. So other than his being currently treated for what was presumed to be latent TB, there were no other medical problems. Hemodynamics were very normal. He was in no acute distress, and he had some minimal right lower quadrant tenderness, but no Murphy sign, no rebound tenderness or peritoneal signs. Next slide. White count was normal. All of his bloods actually looked relatively normal. And because of his abdominal pain and history of TB, we obtained a CT scan. Next slide. And if you'll show that video here, oh, that's fine. Actually, that's fine. Just so you can see some quick clips. So there you can see the cecal inflammation. Next slide. And then again, some more cecal inflammation. And then if you'll hit 2 slides forward. You can see that that he actually has a pretty dilated appendix associated with the inflammation of the cecum. The radiologist actually read this as possible latent TB in the wall of the cecum. So we were stuck with this diagnostic problem, or this therapeutic problem. He probably has appendicitis, and does he also have TB that would put the entire theater team at risk when we're taking this out? So what we ended up doing, next slide, is a laparoscopic mobilization of the cecum and an ileocecectomy laparoscopically, and basically mobilizing the entire right colon, bringing it out, then making a small incision and using a wound protector, an Alexis wound protector device, as we brought this specimen out through the abdominal wound, did an ileocecectomy, put him back together, and on final pathology, he actually had acute appendicitis with inflammation of the cecum, but no actual evidence of mycobacterium in the final specimen. Those are some interesting cases that we've just performed in the past several months from the U.S., and hopefully that was of some interest and entertainment. Thank you so much.
That was great. Thank you very much, Tom. We're currently involved in a bit of live rejigging, so we are now going to hand over to Professor Sagar to, oh, no, we're not going to look at that. We're going to hand over to Professor Sagar, who's going to introduce his colleague from Leeds, and then we may change the program slightly later on as the day goes on.
Thank you, Jill. Yeah, we're skipping through these slides because of a technical issue earlier on this afternoon. It gives me great pleasure to introduce a good friend of mine who works at the world famous St. James University Hospital, the largest teaching hospital in Christendom, actually in the known universe.
Peter, thanks for that underrated introduction, and Jill, and thanks ASGBI for the invitation. Next slide, please. Conservative management of biliary disease has always occurred. In the most part, it's surgeon's choice. We categorise patients as unfit, or we have concerns over a potential hostile abdomen. Less commonly, it's patient choice. And in the NHS, we have to deal with the impact of a lack of resource resulting in treatment delay. There's been recent renewed focus on conservative management of biliary disease due to the COVID pandemic. Next slide. It's impossible in a talk of this length to consider all aspects of biliary disease, but I thought I'd look at 3 areas. Acute biliary pancreatitis, because it is the one condition with the most serious consequences, acute cholecystitis because it's the most common, and whether we should be performing cholecystectomy after ERCP, as I find it a personally interesting question. Next slide, please. So if we look at acute biliary pancreatitis first, the gold standard guidelines for pancreatitis are the APA guidelines published in 2013. And this recommends that we should perform our cholecystectomy for mild biliary pancreatitis on the index admission. Next slide, please. Next slide, please. And we'll look at the evidence that backs that up. In the noughties and tens, there were several audits, before several audits that looked at what happened with acute pancreatitis, because most of the guidelines at that time suggested that it was safe to send the patient home, but you should get the patient back in for surgery within 4 to 6 weeks. However, all health services struggle with resource, and audits from Europe and North America showed that it wasn't possible to get patients back in a timely manner. And we missed that window of opportunity, as we all know that with mild biliary pancreatitis, the longer you leave surgery, the more technically difficult the procedure becomes. Next slide, please. In addition, the impact of the delay in laparoscopic cholecystectomy is demonstrated in this Dutch systematic review. If you wait for an interval lap chole, then there is an 8% incidence of recurrent acute pancreatitis, compared to 1% in the index laparoscopic cholecystectomy group. Despite this study heavily informing the IAP guidelines, the weakness of this study was that it was mostly made up of cohort studies and only one RCT, which is controversial as the lap chole was performed so early before you could determine whether the pancreatitis was going to be mild or severe. Next slide, please. So we've had to wait until 2015 until the Dutch pancreatitis study group published this nice RCT looking at the impact of delay of lap chole. If you wait for an interval lap chole, it shows clearly that there's a 8% incidence of recurrent acute pancreatitis compared to 1% in the index lap chole group. This clearly shows that there's no place for conservative management in acute biliary pancreatitis. If the patient isn't fit for a lap chole, then you need to consider ERCP and sphincterostomy. If not fit for an ERCP, then a frank discussion needs to take place with the patient and importantly relatives, and the outcome clearly recorded. I tell my trainees sending someone home after acute biliary pancreatitis without a lap chole or protection of the CBD is akin to sending an MI home with critical stenosis of the LAD. It's neither acceptable or defendable. Next slide, please. Moving on to cholecystitis, what guidance have we got? Well, we have our nice guidance that recommends that we perform our cholecystectomy within 7 days of diagnosis. The international Tokyo guidelines are a bit more nuanced. For straightforward mild cholecystitis, they recommend a lap chole. But when you get to moderate cholecystitis, which can be defined as just simply a white count of greater than 18, then as well as index lap chole, you can perform a delayed lap chole or even cholecystostomy. What's missing from these guidelines is any reference to conservative management. And that's because there's a paucity of longitudinal studies in the literature. Next slide, please. Next slide, please. There is only one RCT in the literature that looks at the outcome of conservative management compared to lap chole. And this is a small Norwegian study of 210 patients. But it did show after 14 years of follow-up, those that were randomized to conservative management, 55% of patients had avoided a cholecystectomy. Next slide, please. This interesting study by Ravi Vora's group from Nottingham has looked at the same question using HES data on patients that had a diagnosis of, were admitted with a diagnosis of acute cholecystitis between 2002 and 2015. They recorded 99,000 patients, 5,000 were lost to follow-up. And what they found was that 51% of patients, 47,000 patients at 1 year had not undergone a laparoscopic cholecystectomy. And in this group, only 4,000 patients on further follow-up underwent a delayed lap chole, but overall, 47% of patients in England do not get a lap chole following acute cholecystitis. In the operated group, index cholecystectomy on the index omission only occurs in 1/3 of cases. Next slide, please. If we drill down to some of the further data, on the left, we'll see that those that were managed conservatively were older, were more unfit, and had a higher non-biliary mortality at 1 year. When you look at, on the right-hand side, at those that underwent lap chole, there was a higher mortality in the emergency lap chole group, but this group was significantly more comorbid. Despite in the interval lap chole, there are 22% of readmissions. When the groups were matched, there was significantly less time in hospital, spent in hospital when you wait for your lap chole compared to an index lap chole, 17 days versus 13 days. This data suggests that we clearly need to re-examine this area. New slide. Next slide, please. And this is the Seagull study, is a study being currently undertaken by Irfan Ahmed up in Aberdeen. It's an NIHR study that is randomizing patients between observation and conservative management. And looking at the website last night, they're halfway through recruitment. And this may give us some answers well to see who we should operate on and who it's safe to manage conservatively. Next slide, please. My final group is to look at patients who should have cholecystectomy after an ERCP, CBD clearance for gallstone disease. Looking through the literature, there's no really good guidance as what we should do, but I think it's accepted surgical dogma that we take people for gallbladder surgery if they are fit. And what's the evidence behind this? There's 4 RCTs that have compared emergency management to lap chole. They showed that recurrent biliary events were more common in the conservative managed group, but those that underwent surgery, more difficult cholecystectomies were encountered. When this was reviewed in a Cochrane review, they really couldn't come to conclusion because they found it was limited by few trials with low patient numbers and pretty poor methodology in these trials. More recently, the largest retrospective cohort study has been published by El Munza following an American cohort of patients. However, this is flawed that they retrospectively applied expectant management was defined as not having undergone cholecystectomy within 30 days, which in the UK, that would exclude the vast majority of our patients. So in Leeds, we've looked at this question again, and we've got a prospective database of all our ERCPs. And between 2015 and 2018, nearly 2,000 ERCPs were performed in total, and around 850 were for CBD stones. Just over 200 were for ERCPs following a previous lap chole. And in the groups that were interested, nearly 400 were managed expectantly, and 200 underwent cholecystectomy. In the expectant group, as you would imagine, they're older with a median age of 76 years, but only 65 out of the 400 were for personal choice. But importantly, only 9.1% were admitted with a biliary symptom, and only 2.3% were for CBD stones. And in none of those cases were there for pancreatitis. And ultimately, only 1.5% had to undergo an interval cholecystectomy. If we look at the operated group, the surgical group, as some of the previous studies that I've mentioned, 15% of these individuals had a complex cholecystectomy with an extended length of stay. And following surgery, despite having surgery, ERCP and a cholecystectomy, nearly 12% were readmitted on follow-up, and follow-up median time was 3.9 months. So with this data, we went on to look at some national data. Next slide, please. Next slide, please. Sorry, I haven't said next slide. Next slide, please. I don't know what, okay, sorry, I do apologize. When we've looked at national data, we examined the HES database between 2016 and 2018. we identified 41,000 patients that had undergone ERCP for common bile duct stones with clearance. And again, 2/3 of those patients were managed expectantly, and 1/3 were managed with surgery. Of those that were managed expectantly, only 7% of patients had a cholecystectomy at 2 years. Those that underwent surgery, we can't find any correlation between the incidence of surgery and hospital volume. But if you look at the bottom, the most important finding is the readmission data. At 2 years for biliary complications, they're the same in both arms. We think that this area of biliary management warrants further investigation. Next slide, please.
He's nearly done. Oh, we've done.
Andy, you've muted.
It's because he overran.
Okay.
So, sorry, Pete. In summary, there's no place for conservative management for biliary pancreatitis. In other areas of biliary disease, we need further studies to determine who it's safe to manage conservatively. Thank you.
Thanks, Andy. An excellent review of a difficult topic. Back to you, Jill.
That's excellent. Thanks, Andy. I'm not sure if it's apparent to our delegates, despite our swan-like demeanours, we're having 1 or 2 tech hitches behind the scenes in the upper GI session. And as 2 colorectal surgeons, what can we say, Professor Sagar? So with no further ado, I'd like to introduce our next speaker, our next clinical speaker in this session, who is Dimitris Damaskos, who's a consultant surgeon from the Royal Infirmary in Edinburgh. And Dimitris is going to talk to us about abdominal wall reconstruction. Thanks, Dimitris.
Thanks a lot, Jill. Thank you very much for asking me to speak to this session. I have chosen the topic of speaking about abdominal wall emergencies, and especially dealing with the acute complex incisional hernia. Next slide, please. And I wouldn't be able to give you much information on that unless I was privileged enough to work with these 2 people at the Royal Infirmary of Edinburgh, Bruce Tallow and Andrew DeBow. Next slide, please. So to put in some perspective about abdominal wall reconstruction and show how complex it can be, even in the elective setting, complex incisional hernias, we're talking about large hernia defects, we're talking about difficult locations, perhaps loss of domain, fistulas, recurrence after recurrence, and local infections. On a lot of scenarios, these patients would perhaps even be managed non-operatively, and there needs to be good preparation, good optimization, and lately it's been shown that specialist input can contribute a lot to the final outcomes. Next slide, please. So there's been actually an explosion of new techniques over the last, let's say, 10 or 15 years. So apparently the open techniques have been well described, and I've just named a few here in this slide. There's more coming up. And to stopa anterior and posterior component separation, or transversus abdominis release, the peritoneal flap, and that's for open repairs. But again, some of these techniques can also be performed laparoscopically or even robotically, mentioning ICOM, TAP, ETEP, which is a very, let's say, hot debated topic in the hernia surgery world. TARAP and other techniques. Next slide, please. And again, talking about elective repairs, you would have adjuncts to preparing, so preoperative progressive pneumoperitoneum to make space for your operation, and even the use of Botox in order to relax the abdominal wall muscles prior to fixing this. Next slide, please. And lastly, of course, and this slide is more to show the variation rather than staying specifically on going into the specific aspects of it, to show the different types of mesh. There's approximately 150 to 200 different types of mesh in the market, with all with different qualities. And the next slide, please. Again, all this is in the elective domain, but what happens when you don't have any of these in the emergency setting? So you would be dealing with a complex incisional hernia, and mortality and morbidity rates are considerable, having cases of bowel obstruction, bacterial translocation from it, intestinal wall necrosis, need for bowel resection, and on top of that, the patient is not optimized for this operation, and the surgeon undertaking it may not be familiar with all the techniques. Next slide, please. So steps in management, and first of all would be establishing the diagnosis. That would be using a CT scan. There is always the need to make sure that the hernia is the only reason for the patient's bowel obstruction. If the patient presents with bowel obstruction, there is no downstream or upstream reason for the patient's presentation. And also it allows you to assess hernia contents and the anatomy. Again, there will be the occasional case where there are high-risk patients with only omentum sitting inside the hernia sac, which can be dealt with conservatively if they're not fit for an operation. Then the next case, the next step would be to ask if the patient is fit for an operation. There's always the chance that the hernia may reduce spontaneously, or you can try a manual reduction. If the patient is not fit for surgery, then there would have to be a frank discussion between the patient, the surgeon, intensive care, and anesthesia about whether there might be a role for palliation. And of course, if the patient is fit for surgery, then you would talk about the possibility of not having any bowel or dead bowel inside the hernia, in which case you could defer the case and do it in hours with the help of a colleague. If it is complex, you can use a mesh, and you can use a technique you are most comfortable with to achieve a non or perhaps a low tension closure. Next slide, please. If there is dead bowel, then there are three tenets to the management. You would say the first would be to save life, so do a laparotomy and resect the bowel, damage limitation surgery, minimize fascial retraction, and come back. There's also grounds for closing the sac or closing the skin only. Second would be to save the GI tract, so do an anastomosis or do a stoma. And you can do an anastomosis at the same time if the patient is stable, or you can do it at a relook laparoscopy. And the third, which is the thing I would be mostly focusing on, is saving the abdominal wall. So this can be done at the first laparotomy or in a relook laparotomy, or it could be a mediated fascial traction closure, depending on the situation and depending on the confidence of your anastomosis, if you have done one, and depending on the state of the abdominal wall. There is, as mentioned before, the role for using the sac or doing a planned ventral hernia. Next slide, please. And then I chose in this presentation to answer four main dilemmas. So one would be open versus laparoscopic, what to do when you have contamination or potentially contaminated setting. Would you do a component separation in the emergency setting, or what to do if there's undue tension? Next slide. Next slide, please. So overall, there's only one guidance, which is actually from 2020 on the emergency repair of complicated abdominal wall hernias, and that's from the World Society of Emergency Surgery. Next slide. In terms of open versus laparoscopic, and the previous presentations have touched on the subject, there's only two studies on emergency laparoscopic repair of midline hernias. And they talk about uncontaminated abdomen with a 5-centimeter mesh overlap. There's not a lot of other studies on the subject. The recommendation by the World Society of Emergency Surgery is that it could be performed with a laparoscopic approach in the absence of strangulation. And that's a grade 2C recommendation. Next slide, please. Before talking about the potentially contaminated and contaminated setting, I just thought I'd just put on this table to show what we mean by clean, contaminated, and uncontaminated situation, and that's the AAST classification. Next slide, please. The reality is that the evidence so far about using synthetic mesh shows that there is no particular risk in terms of mesh infection, even though there is always there are always second thoughts about using synthetic meshes in the potentially contaminated fields. There's a lot of studies to show that there is no significant risk, either with regards to deep incisional SSIs or return to theater and wound infections. There is only one study, and that's the second one that shows on that slide, that shows a significant postoperative infection incidence in mesh ventral hernia repair with simultaneous bowel resection. Next slide. What about the biologics? You would see on multiple guidelines or consensus papers about using biologics in the emergency setting. However, there's not really high quality evidence on it. There's only one systematic review which says that they can be successfully used. There is a prospective observational study with 71 patients that's been published that in contaminated and potentially contaminated fields using a biological mesh that shows a wound infection rate of 30% and a hernia recurrence of 27%. Next slide. And then there is no difference between using a synthetic non-absorbable mesh versus a biologic mesh according to the study by Lopez Caño, and there is no particular difference with regards to wound morbidity and durable outcomes versus in synthetic sublay versus biologic, and that's likely secondary to improved bacterial clearance and integration of the macropore synthetic mesh. A recently published study in COBRA study that was a single-arm study published in an American journal, which shows that biologic mesh is equivalent, but there was no control group, and all comparisons were made with previous studies. Biologics degrade faster in infected fields, and they degrade even faster than natural native collagen can regenerate. So that's what leads to higher recurrence rates. Next slide, please. So you would say that there is no hard data that biologics are better than synthetic mesh. And when you take into account also the cost, that also raises more the question of whether they should be used or not. Next slide. So what is another trick that you can use? So this video, if you could just start the video, please. That's shown with permission by Dr. Gregory Dumanian. He is a surgeon in Chicago who has devised this technique, which is called the mesh sutured repair. So what he's doing is he's using a standard polypropylene mesh, which he cuts out in strips of 2 centimeters, which he then mounts on a heavy Prolene needle and passes, as you can see here, pulling the thread, passing the mesh strip through the abdominal wall, taking care only to grab the anterior bit of the fascia, and then passing through. And then you will see that he does suture the mesh strip as you would suture a simple suture. He would tell you that 3 knots are enough. And then with that way, you would be able to close the whole abdomen. Could you go on the next slide, please? And so this is kind of a graphic representation of what he has done. And he would also argue in the papers that he has published that even a mesh infection would only result in an infection of the knot and not of in a different scenario where you have placed a whole mesh, then you would have to remove the whole mesh. Whereas in this scenario, you would only have to do a small local anesthetic, take out that infected knot, and that would be it. Next slide, please. Yes, so recommendations is that you would only use by WSCS, and you can use direct sutures, and you could perhaps use a biologic mesh. Next slide. Component separation in the emergency setting. If it's a clean case, if you have the expertise, yes, do it. If it's clean contaminated and you have the expertise, do it. If it's dirty, it's better not to burn a bridge and compromise a future delay. There is no solid data. There is no right answer. Experts would say, save the abdominal wall reconstruction for the definitive repair. If the emergency repair is a definitive repair, then it's okay to do it. Otherwise, don't do it. Next slide. And in the initial dissection, be conservative with all tissues until you're sure you're not going to need it. So every layer can be useful. Next slide. And when there is undue tension, then the tricks you can use is mesh mediated facial traction. There is, I must say that all the data is in the open abdomen and not specifically in the emergency hernia surgery field. But however, you would argue that it is more or less essentially the same problem. And the next slide, you all may be familiar with the mesh-mediated facial traction. There is a variation to the technique recently published, which incorporates the mesh to the edges of the fascia for it to stay as an onlay, so to facilitate the closure. And that's by Peterson on a study that was published last year. Next slide. So you can use also bridging. That's the second technique that you can use, either with resorbable barrier composite meshes or with biologics. Vicryl mesh, you could use it, but it has a high risk of a fistula, or you could just close the skin on top. The WSCS guidelines say cross-linked biological meshes may be considered as a delayed option for abdominal wall reconstruction. Next slide. That's an example of bridging with a biologic mesh. Next slide. So conclusions, they are challenging. Acute complex hernias, laparoscopy may be feasible. Synthetic mesh is safe in clean contaminated cases. The use of biologics, especially when taken into account the cost, is debatable. The mesh sutured repair is a trick. I have used it on a couple of occasions with good outcomes, but there is no solid data on it. Bridging and mesh-mediated facial closures are not described for emergency hernias in particular, but the rationale for their use is perhaps transferable if we're talking about an open abdomen. And always remember the damage control options. Next slide. Thank you very much. And I would just like to take the occasion on this last slide to invite you to our upcoming World Society of Emergency Surgery meeting in Edinburgh in 2021. And hopefully we'll be able to invite you and get you all there physically. Thanks a lot.
Thanks, Demetrios. That might be the first time we ever have a social meeting. Looking at the way things are going with COVID down here in England. Thanks for a very clear presentation. Before we go to questions, we've got a further presentation. I think I'd like to ask Abigail Harper and Holly McDonald to address briefly biosurgery, hemostat, and overview. Abigail.
Microphone. Microphones aren't on.
Apologies, sorry. Good afternoon, everyone. My name's Abby Harper, and this is Holly McDonald, who is the platform manager for ethical biosurgery. And we're just going to take you through a hemostat overview and appropriate hemostat selection. So next slide, please.
Thank you, Abigail. Thank you all. It's been a delight to listen to you all today. So although managing bleeding during surgery is a basic element to any procedure, patient outcomes, hospital costs, and resources can all be adversely affected by surgical bleeding. And managing this appropriately gives surgeons and hospitals an opportunity to improve patient outcomes and these costs. And this is increasingly important, as we've heard today, as we see more complex comorbidities and procedures. And there are many different bleeding situations resulting in lots of different ways to manage this, starting with obviously our conventional methods like Ethicon sutures, clips and energy. However, there may be limitations with the application of these, such as compression when bleeding is diffuse or uneven tissue topography. And the sheer number of choices combined with lack of standardization can lead to suboptimal use of adjunctive hemostats. So Ethicon decided to undertake a quantitative study to understand surgeon mindset. And from this, it was found that surgeons generally consider site and situation as the primary factors in choosing an adjunctive hemostat. And these 5 bleeding situations have emerged. And whilst this is not the only solution for each bleeding situation, they are considered an optimum first choice in the decision-making process. And these brands might be familiar to you, obviously starting with our Surgicel absorbable hemostat being the most trusted TAH on the market for over 60 years now. up to Veriseal, which is now our newest offering of fibrin sealants from Ethicon, being launched this month. And I'll pass you over to Abby now to talk through another one of our latest innovations for managing bleeding.
Next slide, please. Thank you, Holly. So I just want to take you through Surgicel powder. So Surgicel powder is our latest innovation and the 5th member to our Surgicel family. It still holds the same characteristics of being an oxidized regenerated cellulose as well as being bactericidal. But Surgicel powder is different. It allows for the aggregate to penetrate through the blood to the source of the bleeding to provide that really strong and stable clot. And furthermore, then allows you to irrigate any excess product away and out of the patient, remaining and leaving that clot really stable and not to re-bleed post-surgery. It's a really fantastic product. There's 3 grams that allows 15 expressions, so can be used throughout total surgery as well. It is also available in laparoscopic and open tips for your convenience. So thank you very much. And next slide, please.
Thank you. As we've mentioned, Veriseal, and it is a pharmaceutical, we will need to show you our abbreviated prescribing information for the next 2 slides. Thank you so much.
Thank you, Vicky. Thank you, Holly. We'll just go on a few questions before we go for a short break. We've had a few questions that come from the audience, so I'll fire a few questions at you. So going around the various panels, Sarah, 2 things. First of all, we put a great store on re-examining patients. So seeing a patient in SAU, maybe see them on the ward, maybe see them 2 or 3 times. Do you have that in your algorithm is the first question. I think that's invaluable in diagnosing appendicitis without necessarily resorting to radiology. You're muted, Sarah.
Yes, we do. So a patient can come in and be seen in ambulatory care and would be seen the next day. So we always have the facility to see them 24 hours later.
Would that be the same surgeon looking at them? Is there a continuity of care there?
So it's not always the same surgeon. It often is, but we can't guarantee it's always the same surgeon, no. So again, it's down to robust and careful documentation. I'd argue, though, it's not always the same surgeon if they're an inpatient.
Yeah, so it depends on the model you've got. The other question, I don't always like down in Bath, down in the well-resourced south, but we get an awful lot of frequent flyers with non-specific abdominal pain that come in, looked at, go home again, come in several times. Eventually, one of us decides to take the appendix out, more out of frustration than anything else. Any thoughts on how we can manage those patients better?
I think that's the beauty of what I've shown to you, is with all those non-specific abdominal pain, actually very few of them are frequent flyers. I think part of it is the perceived reassurance of having had a consultant see them for 20 minutes and some of the documentation we provide for them afterwards, which is reassurance that functional abdominal pain is genuine and some of the coping mechanisms for that, and most of them leave very satisfied.
Thank you. Question for both Paul and Stuart. Challenge we have with a lot of the emergency surgery, certainly on the colorectal side, is gas-filled bowel. Now, I know you're both upper GI surgeons, but any tips you've got to handling small bowel that's full of gas, or even large bowel that's full of gas and taking a lot of the volume of the abdomen? Paul?
I think with, initially, small bowel is just experience, really. I agree with one of the previous talks in the morning that inflammatory bowel disease is always a significant problem laparoscopically. And if you've got Crohn's bowel, then I think laparoscopy does have limited value because the bowel is so delicate. But in most situations, if there's not a significant delay in diagnosis and you've got a safe access technique for laparoscopy, then it's not normally an issue.
A question for Stuart, maybe then. You mentioned the difficulty of getting access to theatres and the resistance of theatre staff. It's 2020. I'm sure Tom would be a bit surprised with the American standpoint that we're still struggling to get case into theatre. How do we get the theatre staff convinced that laparoscopy is in the benefit of the patient and beneficial to the team in getting good results? Stuart, if you're still there. Maybe he's not. Paul, do you want to tackle that one?
I think, and Jill knows when we work together that access to theatres is always very difficult. Having a dedicated emergency theatre on a daily basis is important, and working with the team and making sure that the team educates the value of laparoscopy in those cases. I think if you're able to get in during the daytime, it's always better because you're more likely to have the availability of appropriate laparoscopically trained theatre staff working with you. So that's always a definite advantage. But having dedicated emergency lists is probably an integral part of the whole process. And working towards readmission with sort of ambulatory care, I think, is an important point as well, just to allow access to the emergency theatres.
Thanks,
Paul,
Paul.
I've got a question.
Sorry.
Just come up question, Paul, that says somebody saw you using a laparoscopic piece of kit that looked like a soft bowel clamp. What's the name of that?
It is a soft bowel clamp.
Just a laparoscopic soft bowel clamp. Okay, that was good.
Almost out of time. One last question for Andy Smith. Andy, you'll be aware that there's quite a wide variation how many lap gallbladders are done by consultants in one unit. In this unit, it's almost a 10-fold difference between the lowest and the highest. How do you incentivize surgeons to be encouraged to take out these gallbladders that come in on their take and seem to hang around for a long time?
I think that's really difficult, Pete. I think in our unit, we maybe not tenfold, we have quite variable rates, and despite audit and presentation of audit, it's difficult to change practice. And I think it also reflects individuals' comfort with these cases. A lot of these cases aren't straightforward and should only be undertaken with a certain skill set in hand or reasonable overhead cover. I think it is an issue, but difficult to address. I'm sorry, I haven't got a magic answer to that.
No, very good answer. Thank you. Okay, folks, thanks for very good talks this afternoon. We'll have a 10-minute break just to let the tech team just get up to speed with the last couple of talks. So if we can come back here at 15:35, please.
Thanks,
everyone.
Thank you.
Thank you.